So the one thing I noticed is that the meeting ID you gave me is different than the meeting ID that's posted.
I just reposted a new link. So what happened is I copy and pasted from my phone while I was on with you, but now I just went back into the event. Now Barb's coming on. So I think it was just a different ID.
Got it.
All right, here we go. Here's our friends. Hi, Lisa. Tracy. Barb.
Hi.
How are you?
Hello?
All right, and then popping on.
Somebody must have had too much to drink last night, because they must be looking up at their ceiling on this one.
Barb.
Where was I?
Really wanted to get on so you guys, I could show you my ceiling. All right, friends, just so you know, you have not missed anything, except for Dan and I chatting. So there were some technical issues, obviously, so I just went ahead and shut down our first meeting and then went ahead and reposted from my computer. I was trying to do it from my phone as well. So I have two different systems going on here. So I have my work because I'm not at home, and then my phone. But you guys are all here. You didn't miss anything. Thank you for following up and posting that you couldn't get on, but now you're all here. So we'll go ahead and I'm gonna mute Kat.
Where'd everybody go?
Some people don't like to have their face showing.
Yeah, I'm one of those people, actually.
Barb is still trying to connect to audio. Not sure what's happening there. But anyway, hi Kat. So Dan, when I have to scooch, do you know how to pop into the chat?
I could probably figure it out. Do you just kind of hit on it and hit chat?
Yeah, you see, so you see the chat button down below in the middle?
Yes.
Okay, so if somebody has a message, it'll pop up. Everybody, if you're gonna do a chat in the Zoom, make sure the drop down is to everyone, not just an individual. So that means that everyone can see it. I'm gonna have to go teach a class shortly. So I am gonna go ahead and make Dan the host of this, just to let you know.
We already went through this. Yay, I'm someone. I'm a host.
So if you see me disappear and all you see is my logo, then you know why. All right, you are officially the host.
All right.
All you, my friend.
All right, so unless anybody has any objections, I'm actually going to share my screen if I can do this properly. I'm a very newbie person at this. So I'm not real sure what I'm doing yet. One participant can share at a time. Okay, I'm good with that. That's not what I wanted. That's what I wanted. All right. Can you guys see all that?
No.
What?
I see a Brady Bunch screen.
Well, that's not good.
So when you click on the screen that you're trying to show, don't forget to go down to the bottom where it says share.
Yeah, I thought I did that, but I'll do it again. Woohoo.
All right, perfect.
This is kind of boring. So how is everyone? Everybody good? Can you guys see the whole screen?
Yes, and everybody else is on the side over here.
Yeah, I know I see everybody on the side. So you guys are actually going to be able to see the previews over here too, because I just don't know how to get rid of those. I could probably go into view and figure that out, right?
I don't think anybody really cares.
Yeah, me neither.
They just want the information.
And there's so much good information.
I know, but first tell them about you and how awesome you are.
So I kind of went over this a little bit earlier with Shannon.
That was your trial run.
Yeah, that was a good trial run. So I started in fitness when I was 18, and I'm not going to tell you how long ago that was because I started actually taking martial arts classes. And at the time, I was really small. And I'm like, I need to get stronger. So maybe I'll start lifting weights. Okay, so I started lifting weights. And then I started doing other stuff. Anyway, so one thing led to another. And fast forward a number of years, and I had an opportunity to open my own business. And what I wanted to do was open up a martial arts school, but focusing on the personal training method of it. For the same reason that people want to do personal training for the individualized programming, martial arts actually should be the same way. Because just like everything else, not one art or one thing will fit everyone. So I did that. But what I soon realized was that martial arts attracts a demographic that there's high turnover. Whereas I realized shortly after that fitness actually has a demographic that wants to stay with you. And then I started training more and more people with chronic diseases, and they stuck with me for years. And then they sent their friends and they told their doctors about me. And so I figured, maybe I should actually start learning about at least a little bit about what I'm doing. So I got one degree. I kind of one day looked at my wife and said, maybe I should finish my undergrad. And she's like, yeah, okay, that's a great idea. And she had her master's at the time. So I got close to finishing my undergrad, and I thought, everybody's really doing anything actually as a master's degree. So maybe I'll get a master's degree. So I went and finished that, and then 6 months before being done with that, I kind of realized I'm burned out from what I'm doing. The one-on-one training is starting to get to me on an ongoing regular basis. So I said, maybe I'll get my doctorate and start teaching classes. So I finished my doctorate. And just so you know, as I go through this program, as I go through this PowerPoint, my brain and my mouth often don't engage at the same rate. And that tends to get me into a lot of trouble. So I have notes that I'm going to be looking at here and there to kind of go over some of this stuff. But so fast forward, I finished my master's and my doctorate, and there I am after finishing my doctorate. I was a happy camper. But during that time, I spent getting my master's and my doctorate, I started to realize there is a huge gap in our healthcare system. And it's mostly, why are we not using exercise and activity in primary, secondary, and tertiary prevention? So I started to do the research on it, and that led me to my dissertation, which was published in 2018. And then ultimately, the latest thing I've worked on and is now being formatted for ebook and for hard copy is Clinical Exercise Specialist Manual, the textbook for it. So that's what brings me here today.
Yeah, I don't know if she did both of them or if she gave them.
I'm sorry, what was that?
I think somebody unmuted for a second. You're good.
Okay. Anyway, so clinical exercise in cancer. We all know what cancer is, but what's clinical exercise? Why is it important? And how does it fit into the healthcare continuum for cancer? So I'm going to go over clinical exercise first, and then we'll go over a couple of things, comorbidities with cancer. So first, the what. So in addition to use as primary prevention, clinical exercise helps patients move from rehab to clinical intervention to conventional fitness programs. So a clinical exercise specialist develops exercise programs for individuals or groups who have or are at risk for chronic disease or dysfunction, or those who may need some specialized care. So that kind of explains the what, but now the why. So in the United States, adults have decreased their number of steps per day by 70% since the Industrial Revolution. Time in front of the television has increased by 1% per year for more than the past 50 years. So today, screen time is estimated to be 7.5 hours a day for children and adolescents. That adds up to 114 days per year of screen time. More screen time is associated with lower psychological well-being, less curiosity, lower self-control, more distractibility, more difficulty making friends, less emotional stability, more difficult to care for, and the inability to finish tasks. So where that leads us, though, is the average adult only spends 1 to 5% each day performing moderate to vigorous activity. And less than 23% of US adults aged 18 to 65 meet the recommendations for aerobic and muscle strengthening exercise. And just so everybody's kind of on the same page, this is what that is. These are the current recommendations. These are the FIT guidelines, which stands for frequency, intensity, time, and type. These are the current guidelines that have been put out by, I don't know, whatever government agency does it, an ACSM. But what's important to remember is that these guidelines are for healthy individuals. Frequency, intensity, time, and type need to be considered not only for the mode of exercise that the person's performing, but also for each individual, their circumstances based on assessments, and that includes any chronic disease. So here's a pop quiz, and you don't really have to answer it because we probably already all know the answer. What is Newton's third law of motion? So if you said for every action there was an equal and opposite reaction, you are correct. So give yourself a pat on the back for that. But what this means to us, so the consequences of our inactivity, the action to our inaction should be, is over 70% of the US adult population is overweight or obese. 63 million have chronic joint complaints. 50% have at least one chronic disease. And there, by some estimates, that's up as high as 60%. And that rate is rising. The rate of comorbidities is rising. Adults under the age of 65, 25% have more than one chronic disease. And by 2030, there's going to be 70 million US adults age 65 and over, and almost 75% of them will have multiple chronic diseases and conditions. So unfortunately, due to lifestyle shifts, poor nutrition, increased inactivity, chronic disease is now affecting all of us, the population, at a younger age. But at the same time, our lifespans are increasing. So in 1970, we lived to about 70 years. Now it's up to almost 79 years. So this means we are going to live with chronic diseases or conditions for a much longer period of time. So then that takes us to the next question. What is a chronic disease? And if anybody's old enough, you remember Mr. Yuck there, one of my favorite stickers. A chronic disease is a disease that is slow in progression and long in its continuance, as opposed to an acute disease, which is characterized by a swift onset and short course. So, all right, chronic diseases include, and I took a deep breath for this because there's a lot of them, low cardiorespiratory fitness, asthma, sarcopenia, metabolic syndrome, obesity, insulin resistance, prediabetes, diabetes, type 2 diabetes, cardiovascular disease, peripheral artery disease, prehypertension, hypertension, stroke, endothelial dysfunction, arterial dysfunction, hemostasis, deep vein thrombosis, cognitive dysfunction, depression, anxiety, osteoporosis, osteopenia, osteoarthritis, balance disorders, bone fracture, rheumatoid arthritis, and other autoimmune disorders, the various forms of cancer, and some conditions brought about by pregnancy. So if you've taken any class, college class, whatever, or you've done any research, you know the number one question you have to ask is, so what? Listing facts and stats isn't enough. You have to answer the so what question. So where does all of this lead us? So today, 70% of deaths in the US can be attributed to chronic disease. There's an associated cost with that of 3.7 trillion in medical expense, lost income, and reduced productivity. 1.4 of that trillion is attributed to just cardiovascular disease, and obesity is by far considered the greatest burden, and it costs almost 2 trillion, almost 2 trillion annually. So again, what does all this mean? Sedentary lifestyle leads to higher incidence of chronic disease, and the combined result is an unhealthy and aging population. It places an undue financial burden on society and taxes an already strained healthcare system. So we've discussed what clinical exercise is, and we kind of just went over why it's important. So how does a fitness professional fit into all of this? This has got to be my favorite quote of all time, and I found it while I was working on my doctoral dissertation. If we could give every individual the right amount of nourishment and exercise, not too little, not too much, we would have found the safest way to health. Hippocrates said that over 2,000 years ago. So here's what we know. current model of healthcare in the United States is based on treatment rather than prevention. Treatment is given for a disease or injury that has been diagnosed, whereas prevention is taking measures to avoid or improve a probable or possible disease or injury. So what are the levels of prevention? And the levels of prevention are primary, secondary, or tertiary. The goal of primary prevention is to stop a condition before it starts. Immunizations, targeted types of exercise and wellness programs and education are examples of primary prevention. Secondary prevention interrupts a progression of disease in the hopes of slowing down or reversing that progression. And examples include treatment for hypertension, asthma, and some cancer treatments. Tertiary prevention is the treatment of symptomatic disease where the disease will most likely not be able to be reversed, but the goal is to reduce the severity, help restore function, and to reduce any disease-related complications. And treatments for that can include late-stage cancer, coronary heart disease, and some forms of rehabilitation. We also know, though, that physical activity can positively affect over 30 chronic conditions, making it the #1 deterrent of chronic disease in primary and secondary prevention. Therefore, the main goal of clinical exercise in the healthcare continuum is to prevent the onset of chronic disease. In other words, 2,000 years ago, Hippocrates was correct. Illness is caused, at least in part, by the lack of exercise. So if you've been doing this a while, you probably get one of the biggest questions, and the question I get all the time is, why don't physicians take the lead on this? Training a physician to become a fitness expert may actually encourage them to prescribe and oversee physical activity. But as of now, only 1 in 3 adults is advised by their physician to increase physical activity. Only 6% of medical schools provide information on exercise testing and prescription. And in a recent survey, I should say, of med schools in the US, 80% of the schools surveyed offered no course or only a single course related to exercise. And in 80% of those schools, it was not a required course. So because of a lack of education in exercise programming and prescription, only 10% of physicians are confident in designing an exercise plan. And that's kind of rightfully so. If you look at the demands on and constraints on medical school curricula, they already have a lot to learn in med school. And physicians' time is probably very tight as well. So a better approach might be to educate fitness professionals in the prevention and management of chronic disease. And honestly, so this is where we come in. We are or should be specialists who study human movement and its effect on health and quality of life. So it makes sense that fitness professionals who are trained in exercise programming may actually be better prepared to design and implement clinical fitness programs. And then the next question I get is, so what does that look like and how does that fit in? So the first thing we need to do is we need to go over what scope of practice is. Scope of practice refers to the specific boundaries based on knowledge, skills, and abilities in which a professional can work. By offering clinical exercise services of any kind, it is implied that the trainer offering those services has the knowledge, skills, and ability to design an effective exercise program based on the client's physiological needs. Okay, a clinical exercise professional should have advanced education and management of chronic disease to include their role in the scope in the healthcare continuum, pathophysiology and physiological implications to exercise, common medications and their interactions, common diagnostic criteria, assessments, and tests, exercise and activity progression from clinical care to rehab to mainstream fitness, contraindications, progression or regressions of movement, and common medical jargon, okay? Keep in mind, a clinical exercise professional may not, unless they are otherwise licensed to do so, touch a client, perform a nutritional assessment or prescribe a dietary plan, or diagnose or chase pain. And that leads us up, yes.
Two things. One, Tracy Green has a question there. She says, quote, gym class is not as in demand in schools, question mark.
That's true. That's a huge problem. That's an entirely separate Actually,
That's a separate webinar?
yeah, it's really an entirely separate issue. And it's because people don't place as much emphasis on, unfortunately, it was always termed athletics, you know?
Plus.
And since tech guys started making more money than athletes, people want to be tech people now. And so they go to school to do that, and they don't go to school to learn how to be active anymore. It's a shame. And there's an entire, that's a whole different thing in population health that, you know, we can actually get into one of these days. And I agree with you. It's unfortunate. And I actually have a paper with all the statistics of phys ed and it being cut out. Even more importantly, though, it's starting school at a younger age, starting school in preschool. There's been so many studies done that kids who go to preschool, in other words, pre-K, they have better outcomes in life, and that includes better health, better financial stability, better emotional stability. If you look at all the 11 or 12 determinants of wellness, they're better in most of those categories than kids that don't go to preschool. So again, it's a whole different can of worms to open up, but you're absolutely right. And it's a shame.
Go teach. So you guys have an awesome webinar. Sorry for all the confusion, guys. This is being recorded. So when this is done, I'll be able to upload it. It may not be till tomorrow because I have to teach tonight. So this will be uploaded into the mastermind group as well, just so you know. And then I send everything to Andrea. She'll put it in your teachable portal under mastermind as well. So you guys have an awesome presentation. Thank you so much, Dr. Dan, for doing this. And you guys have an awesome night. You are now in charge as the host. You
guys should be very frightened now. If you have a question, please unmute. I can't actually see that sidebar with comments and questions. So if you have a question, please unmute and just shout or something and I'll stop, okay? If that works for everybody. So where were we? Yeah, don't touch a client, don't prescribe dietary plans, and don't diagnose or chase pain unless you are otherwise licensed to do so. So that actually leads us into interprofessional collaboration. So according to the World Health Organization, interprofessional collaboration is when multiple healthcare workers from different professional backgrounds work together with patients, families, caregivers, and communities to deliver the highest quality of care. And our fitness professional, our role is to work with the client's team of other healthcare providers in primary, secondary, or tertiary prevention with the idea of progressing clients from rehab to functional to healthy to fit, and if the client wants to, then on to performance. And that team may be a nutritionist, registered dietitian, a physical therapist or rehabilitation specialist, massage therapist, chiropractor, a mind and body specialist such as yoga, tai chi, or meditation. Regardless of all of that, the client's referring physician, whether it's an orthopedist, oncologist, urologist, whatever it might be, nephrologist, the physician is the center of the client's healthcare team and should be provided regular updates as to the client's progress. To work effectively in a healthcare team, a clinical exercise specialist or professional needs to understand the implications of a client's disease and how exercise and activity will affect healthcare outcomes. So that takes us into comorbidities. The comorbidity is the existence of a disorder or dysfunction in the addition to a primary disease. And for this presentation, and for most of us here as cancer exercise specialists, the primary disease is cancer. Cancer patients with comorbidities have higher healthcare costs, reduced survival rates, and reduced quality of life. Up to 60% of cancer patients have at least 2 comorbidities, and almost 90% of older cancer patients have more than 3 comorbidities. Approximately 60% of older adults with cancer report a functional limitation related to that comorbidity. And that functional limitation, that impaired function, is associated with all-cause mortality, which is higher in cancer patients with comorbidities. So unfortunately, it's also beyond the scope of this presentation to explore each chronic disease in depth. If you want to do that, please get on my mailing list, email me, call me, get a hold of Andrea. When my textbook comes out, hopefully in August, it's got 20 or so different chronic diseases in there. So, but as you just noticed, the stats indicate that someone who works with cancer patients, so absolutely needs to understand the implications of cancer exercise and on the different types of cancer, but also on the other chronic diseases that someone may have. So the most common comorbidities associated with cancer are cardiovascular disease, metabolic conditions, including obesity and diabetes, and musculoskeletal disease. So the number one comorbid condition with cancer is cardiovascular disease, and that includes coronary heart disease, hypertension, peripheral artery disease. And you can see on the screen there the cardiovascular disease and the stats with cancer. 13 to 14 million people have it. 1.2 million deaths annually from CVD. Systemic inflammation is the most common marker between cardiovascular disease and cancer. So keep that in mind. Hypertension is the most common chronic disease, the most costly chronic disease associated with cardiovascular disease and cancer, but it is also the most preventable. It is estimated adults 50 years or over have a 90% chance of developing hypertension. Think about it, 50 years. That's so young in today's society, but they're going to live probably almost half their lives with hypertension unless something's done. Hypertension is characterized by blood pressure of greater than 140/90, or prehypertension starts at 120/80. In primary hypertension, the cause is unknown, and that accounts for about 95% of all cases. Secondary hypertension has a known underlying cause, can be attributed to obesity, insulin resistance, high alcohol consumption, aging, sedentary lifestyle, stress, high sodium consumption, low daily fiber consumption, and a lack of potassium and/or calcium. Hypertension is an independent risk factor for coronary artery disease, stroke, renal failure, heart failure, sudden cardiac death, cardiomyopathy, and aortic aneurysms. Accordingly, as that last little line there shows, the higher the blood pressure, the greater risk for a cardiovascular event, kidney failure, or stroke. And as I mentioned, although unless otherwise licensed to do so, we cannot discuss or design a food plan with our clients. We can discuss basic nutrition facts. So for hypertension, what we know is that somebody with hypertension should have no more than 1,500 milligrams of sodium a day. And just for, as a heads up for the general population, that number is about 2,400 milligrams. Lower amounts of sodium reduces blood pressure and the risk of clogged arteries and congestive heart failure. The dietary reference intake for potassium is 4,700 milligrams a day, and calcium it's 1,000 to 1,300. Potassium and calcium have an inverse relationship with sodium on blood pressure. In other words, the more that's consumed, the lower the BP. Less is needed when less sodium is ingested. The recommended daily fiber intake is 28 to 30 grams per day, and an increase of daily fiber has been associated with lower blood pressure, although exact amounts have not been properly studied. So that 28 to 30 is a guideline. Increasing the consumption of fruits and vegetables is preferable over taking supplements due to other vitamins and minerals that are not always found in supplements. However, as we all know, somebody going through some treatments for cancer, they don't want to eat anything. Obviously they need food, but if somebody's not going to eat, give them supplements, okay? Or find those really high nutritious foods to give them. Also, there is not a specific recommendation for alcohol consumption. It is advised to drink moderately, and what that means is 1 drink per day for women and 2 drinks per day for men. What's really cool about this, and this is a very little known fact, 2 or fewer drinks per day, or 1 per day for women, can reduce blood pressure by relaxing the endothelial cells within the blood vessels. It allows the blood to flow a little better. More than 2 drinks a day, though, increases that activity and therefore increases blood pressure. So if you are going to work with somebody that has hypertension as well as cancer, what are the major points to remember, particularly when somebody's on medication such as beta blockers? And the first thing to remember is hydration. And the second thing you have to always look at is RPE for intensity and stand up slowly. So this chart actually, I'm going to leave it up here for a second. It's got the pharmacological therapies generally used for hypertension. Doesn't have everything because that would be, the chart would take up way too much space, but it has the main, the main categories. So beta blockers stunt the heart rate, so exercise intensity needs to be measured by RPE. Diuretics can cause dehydration. Hydrate, hydrate, hydrate. We should be doing that anyways. ACE inhibitors have relatively few side effects, but may cause hypotension. So that can lead to dizziness when somebody's standing upright or they're exercising too much. Calcium channel blockers and ARBs stunt the heart rate. They may cause orthostatic hypotension, which can lead to headaches, dizziness. So you're going to have to use RPE to measure intensity and be cautious when moving into upright positions anyways. And this next slide actually shows the FIT guidelines for hypertension. I'm going to leave this up for a minute so you can look at it if you want. If not, I think, again, this is all available. I think Andrea said, or Shannon said that this is all going to be recorded and put up. So it's important to keep in mind that we should not work with clients who have uncontrollable hypertension. Also know that weight gain increases hypertension. So aerobic exercise can lower BP by 5 to 7 points, and resistance training can lower BP by 2 to 3 points. Because increased weight negatively affects blood pressure, clients should work toward an expenditure of 2,000 calories per week with a focus on aerobic exercise. And due to post-exercise hypotension, it's recommended clients with hypertension perform aerobic exercise on most days of the week with an intensity of 40 to 60% of their heart rate reserve, or an RPE of 11 to 13 on the 6 to 20 Borg scale. Because aerobic training lowers BP to a greater extent than resistance training should be used as an adjunct to aerobic training and performed 2 to 3 days per week at an intensity of 60 to 80% of a 1 rep max. And basically what all this comes down to is the higher level of fitness, the better off you're going to be. And that's, I think we all know that, and that's pretty much with everything. Now, with all the great stuff, there are some things we actually have to be aware of. And here's a list of contraindications and indications for stopping exercise. So it's possible in clients with hypertension that an increase in arterial blood pressure may dislodge arterial plaque, causing a heart attack or stroke, okay? Any existing endothelial damage may also be exacerbated. And due to a reduction of blood flow to the skin, clients with hypertension may not be able to dissipate heat very effectively. So exercise intensity needs to be monitored and or modified and ended at the first sign of heat stress. And as mentioned, beta blockers blunt the normal heart rate response, so the RPE scale will have to be used to gauge exercise intensity for most people, okay? And even with all of that great information, and I know it was fast, you still need to talk to your client's physician regarding any restrictions due to hypertension, but also due to a diagnosis of cancer, okay? So if you guys are with me, I'm gonna go over a little bit on metabolic disease also. So, and the reason is metabolic disease is the second leading comorbidity for cancer patients. There's a lot of emerging evidence suggesting cancer may be as much, if not more, of a metabolic disease than a genetic disease, potentially leading to metabolic syndrome, which is a cluster of risk factors that increases the threat for developing cardiovascular disease and type 2 diabetes. Combined, obesity and diabetes have been linked to over a dozen types of cancer, including all the ones listed here. I'll let you take a look at that for a second. So diabetes occurs when there's a disruption in the production of insulin, resulting in hyperglycemia or increased blood glucose. According to the CDC, more than 100 million Americans have diabetes or pre-diabetic. That's about a third of our country. Diabetes costs the US over $300 billion annually in medical costs and lost productivity. Can also be linked to over 300,000 deaths annually. And the incidence of type 1 diabetes is only 5 to 10% of total diabetics. Also, type 1 diabetes is considered an autoimmune disease where the pancreas is damaged and does not produce insulin. The remaining 90 to 95% of diabetics are classified as type 2. And that's when the pancreas does produce insulin, but due to insulin resistance or the lack of sensitivity to insulin in fat, liver, or muscle cells, it cannot produce enough. Type 1 diabetics do not have a uniform response to exercise. Therefore, trying to determine that dose relationship to exercise is extremely difficult. Type 2 diabetics, exercise can be used in addition to proper nutrition and medication. And that will help improve insulin sensitivity and lower A1C. It will lower blood pressure and cholesterol. Somebody can lose or maintain weight. It increases energy and improves circulation. And here are the FIT guidelines for diabetics. And it's recommended clients with type 2 diabetes be active 5 to 7 days per week, beginning with 20 minutes per day. And if that's not possible, as it's not for some people, start with what they can do. And the idea is to, when you split that up into shorter sessions, the idea is to progress to 60 minutes a day. And that's using a combination of aerobic and resistance training. And similar to hypertension, many diabetics are on medication, and some of those medications have potential side effects. And here is a list of some of those common medications available. Each medication has its own precautions. It's important to know what medication a client is taking and what the side effects are, keeping in mind the most prevalent side effect of diabetes medication and exercise combined is hypoglycemia or low blood sugar. And then although the exercise recommendations are similar for clients with type 2 diabetes as compared to healthy individuals, there are a number of precautions a fitness trainer should take. As mentioned, we can work with clients who have controlled type 2 diabetes. However, as regular exercise alone is not an effective means of controlling type 1 diabetes, clients with type 1 diabetes should be referred to an exercise professional with specialized training and experience. And while aerobic exercise is known to decrease blood glucose levels, resistance training has been known to lessen the risk of exercise-induced hypoglycemia. So to reduce the chance of experience an exercise-induced hypoglycemia event, it's recommended resistance exercise is performed prior to aerobic exercise. A medical clearance is probably necessary. A medically supervised exercise test may need to be performed prior to beginning an exercise program. And that should be actually left up to the discretion of the client's physician, who you should be checking with. Previously sedentary clients may need to start at a very, very low intensity for both aerobic and resistance training. Hypoglycemia is the most common response to exercise, and be aware of the symptoms: profuse sweating, cold, clammy skin, maybe shaking, persistent shaking, confusion, slurred speech, dizziness, or fainting. If a client is displaying hypoglycemic symptoms, a simple sugar snack containing 20 to 30 grams of carbohydrates can help. Blood glucose should be monitored prior, during, and after exercise by the client, unless you are medically trained to monitor blood glucose. The client has to do that. Be cautious with dehydration. The main caution, though, with diabetics, other than hypoglycemia, is retinopathy and neuropathy. So they should avoid vigorous exercise due to the potential for eye or bone damage. The last thing to keep in mind with this is because 75% of individuals with type 2 diabetes will die from a cardiovascular event, be cautious and aware when performing vigorous exercise with your clients. And similar to hypertension, there's that red phone. You still need to talk to your client's physician regarding any restrictions due to diabetes, but also the diagnosis of cancer. And then here is my contact info. And as I mentioned at the beginning, I do actually have a continuing ed program, clinical exercise specialist. It's been approved for continuing ed units, 1.9 by NASM, 15 by AFA, and 2 years worth by NESTA. So let me close my screen here if I can figure out exactly how to do this. And then if you guys, why is this not working? I can pause share. How do I stop share? Stop share. There we go. And I'm back. Hi, guys. So does anybody have any questions? Yippers. Technology is awesome. Yes. Yes. Pam?
Yes, hi.
Hey.
I have a question. Are we
Yes.
getting any closer to dealing with insurance companies looking at the fitness professional? Or are we still, back in the day, I keep hearing it the last 20 years I've been in the business, and it's like, oh, will we ever get there, especially with all the, I've worked with cancer survivors for 10 years at a hospital environment.
Yeah. So when you do it in a hospital, you can probably get some stuff covered, right?
Right.
Yeah. In private practice right now, the answer is yes and no. You can, but it takes a lot of hoops to jump through. I've actually been discussing someone who we're trying to figure out a collaboration we can do together he has a business model where he does take insurance for fitness clients. And there's a lot of paperwork and red tape that has to be very similar to what a chiropractor, or even more along the lines of what a physical therapist has to do,
Right.
to be able to take insurance. So I gotta be honest, and I get this question asked a lot. My question is, why, when there are so many other people, why at a time when so many physicians and clinicians are trying to get out of taking insurance, do we want to take insurance? And I'll explain my answer for this. And I know that the most common answer I get when I ask that question is because it will give somebody that could otherwise not afford it a chance to come in and do something. And that's true. But we could lower our rates for that too.
Right. Definitely. Oh yeah. And that too.
So there's that way to get around that.
Yeah, although I've seen a lot that, because I've worked in the environment for so long, I've seen so many people financially devastated from it. So,
I would imagine. Yeah.
And even giving, and I actually do free, I used to do free classes till COVID. I was doing free volunteering time and doing free classes.
That's great.
And things like that. So I lost my father to cancer 15 years ago. So it's my passion, and it has been for years. So I truly believe in giving it back. But then there's a point where, wow, they could do so much. We could do so much more, I guess.
So one of the inroads that a lot of places are taking also are getting licensed as a wellness coach, because wellness coaching is very, very close on the verge of being able to accept insurance for their services. And if you're trained as a fitness professional and a wellness coach, then who's to say that part of your wellness coaching can't include fitness stuff, which it should anyways.
Right.
And I would actually go to yogamedco.com. Susie Carmack is the person that runs that, and she is absolutely phenomenal. And she's actually transferred all of her in-person stuff to online stuff now. She's done a phenomenal job with it. Check out her information. She's absolutely phenomenal.
Okay, thank you. Thanks.
And I don't get anything for that, by the way. So does anybody else have any questions? No? All right.
No question, but I do want to say I appreciate everything that you shared here.
Oh, well, thank you.
Yeah, I think it was very important. And comorbidities is not something that's talked about as a subject, a standalone subject. So I think it was very good that you brought this to us.
And hopefully, as my course, Andrea and I have been talking over the past couple of weeks to get my course up on her website as well.
Oh, great.
So you guys should be able to access that through her stuff as well. And we got to kind of figure out what all the intricacies of that and implications of that are. So we're going to start trying to do that over the next couple of weeks. Now that, we both have a little more time because of, COVID-19 did that to pretty much
everyone. It might be the first textbook I'm looking forward to reading. Oh, good.
I appreciate that. And I hope you won't be disappointed. But yeah, the idea is, the textbook actually came because I was originally developing the clinical exercise specialist program for trainers who I wanted to work with me. I couldn't find anybody who was qualified to pass clients on to. Oh. And so I'm like, all right, so what do I have to do? Oh, you know what? I'll put together a program and I'll train them myself. You know what? Very few trainers really want to learn more. they just kind of want to stick in their space and do what they're doing. Hopefully, I shouldn't say hopefully, but well, hopefully this has been a wake-up call. Knowing that the number one deterrent and symptom fighter of COVID-19 is current health.
Mm-hmm.
You know, the better health you're in, the better you're going to be able to fight off the current, you know, if you get it, that you're going to be able to fight it off better. So, but also everything's changing, you know, and we need to change with it. And I think a lot of education is going to have to be geared toward that now. So hopefully this will work. But as I said, this will go on Andrea's website, hopefully in the very near future. And also it will probably get onto the Functional Aging Institute website as well.
Great.
Okay.
Thank you.
Oh, you're quite welcome. Any questions or comments? No? All right, guys. I appreciate your time. Email me, dan@medex.fit, if you have any questions. And I look forward to hearing from you guys.
Thank you.
Thank you. I appreciate you guys sticking in and helping us work through our technical difficulties as we did this today.
No problem.
Thanks. Take care.